Hi, my name is Lauren Madigan. I'm an associate professor of dermatology at the University of Utah and part of the Mastocytosis Center of Excellence at the Huntsman Cancer Institute. Yes, we presented the open label extension data from the Pioneer trial. So Pioneer is a trial looking at Avapritinib, an oral selective inhibitor of KIT D816V for the treatment of indolent systemic mastocytosis. It's a really exciting drug because approximately 95% of adults with ISM, it'll be the D816V mutation is pathogenic, and so a good opportunity to treat most of our patients with a really selective drug. Uh, the data that we presented at this meeting was the median of approximately 4 years. And what we noticed is that we saw durable improvements from that initial sort of 6-month phase 2 period through the 4-year kind of median extension time. Durability in the improvement in skin symptoms, improvement in the appearance of skin lesions, as well as objective measurements like skin color and skin lesional density, all improving and either showing durable or further benefit the longer out you go in year 1 and year 4. Overall, a really, good safety profile, nothing too significant in, this extension phase from the initial part 2 phase. Only 6 patients had to discontinue the medication because of treatment-related adverse events out of about 226. So again, an overall well-tolerated medication as well. Yeah, so with systemic mastocytosis, I think one of the opportunities for dermatologists that we tend to be the gatekeeper for this disease. Most adult patients with ISM are going to have fixed skin lesions, and that's one of the few specific signs of disease. So as dermatologists, I think identifying these patients and being aware that we have better therapies to offer them now so that we can, get them appropriately staged and so they have access. There's also ongoing clinical trials for next generation selective TKIs that are coming down the pipeline as well. So really actually very exciting time in systemic mastocytosis. I think it was a condition for a long time. We didn't have as much to offer patients outside of like best supportive care, like antihistamines and things like that. And now we have very selective drugs targeting the actual mutation that causes disease, and they're pretty powerful. Yeah. Yeah, so VEXAS is a fascinating hematoinflammatory disease, also clonally driven. So I think that was like also my theme of the meeting. It's driven by the UBA1 gene, which is on the X chromosome. So it's an X-linked acquired autoinflammatory disorder. So generally a disorder affecting adult men. Usually over the age of 50, there's been one case of a pathogenic mutation with clinical symptoms in a man that was 23. I think that's still the youngest, but generally, if you're seeing an adult male patient who has features of autoinflammation, so like maybe non-infectious fevers, high ESR, CRP, that has hematologic issues like cytopenias, the most common being macrocytic anemia, and then skin lesions like neutrophilic dermatitis, chondritis, or vasculitis, vasculopathy. All of those things should really, raise a antenna in your mind in terms of thinking about screening for UBA1, because if these patients are fairly treatment refractory, so if you treat them like typical sweets or chondritis, they tend not to respond. So really important to identify them. Really high mortality rate, I think, in that disease. We're still working to try to find a therapy that's effective for the majority of patients. We have okay therapies and things like IL-6 inhibitors or ruxolitinib, but really still, sort of the response rates are still relatively low for something that carries such a high mortality and morbidity. And a lot of patients end up being sort of steroid dependent. So there have been newer investigations into azacitidine and stem cell transplant to actually treat the clone. The problem is when you're dealing with an elderly, frail male population, not every patient is going to, be able to withstand those therapies. So there is also a clinical trial that'll be ongoing for VEXAS soon, and we're all very hopeful that maybe we'll see some really meaningful improvements with that. So still a bit of work to go there. We know the gene, we know the driver, but now we've got to find the good drug there. I'm an inpatient dermatologist, so I always love to promote inpatient dermatology. Hospitalist dermatology is, outside of mastocytosis, like the thing nearest and dearest to my heart. So there have been some exceptional talks at the conference this year, including at the Society of Dermatology Hospitalists and MedDerm Society. So a plug for those, sort of para meetings as well. I've learned a ton from my colleagues, and I've learned a ton from all of the sessions I've spoken as well.